How's everybody this afternoon? We got a good crowd. This is exciting. So, in 1993, 5 very brave healthcare and mental health care facilities in eastern Montana took a leap of faith and said, you know, we'll try this interactive video conferencing technology to see if we can improve access to medical and mental health services in the region. And it was a leap of faith, and if any of you were around at that time, equipment, a piece of video conferencing equipment cost $50,000, $80,000, because Doris wrote the grants. You had poor telecommunication infrastructure out there, and it really was a leap of faith. But I want to fast forward now to 2017, and this is 24 years later, and this is a good thing. I started telemedicine, I got married, and there was a third thing I forgot. So I always remember how many years I've been married, because it's 24 years. But go forward 24 years, and what we really have now today in Montana is a robust telehealth environment that encompasses multiple services and utilizes varied technology platforms. Montana continues to have robust telehealth networks, which have long been kind of the backbone of telemedicine services in Montana. And in our state, and the members of the Montana Telehealth Alliance connect 72 communities throughout Montana through this interactive video conferencing backbone. And we provide a wide array of both clinical and non-clinical services to our region. But there are changes occurring, and there's changes occurring at the national level, and there are changes occurring in our state level. So what's happening? Number one, technology has changed. Cheaper, better, faster, more reliable. I remember the day that I rolled what was a 500-pound rollabout cart into the health conference center where I work to connect to all of the county commissioners in the state to show off video conferencing technology. We ended up having to write because we couldn't get any audio signal. So that is not an acceptable use of video conferencing or way video conferencing works today. The other thing that I think that's occurred is that our regulatory environment has improved, and I think Ian's going to talk about that today. Also, reimbursement has improved for telehealth. When we started telehealth, there was no reimbursement at all. It was just, let's try it and see what happens. And healthcare delivery systems have changed, and there's more pressure on systems to do things more efficiently, more effectively, and with quality-based. And also, our ability to provide telemedicine services has changed in the technology, and this is happening in Montana today. So today, software and cloud-based platforms are changing the way we think about connectivity. A computer with a camera and a microphone can become an endpoint anywhere. Secure device connectivity from smartphones, laptops, iPads, expanding the potential site of service. Embedded software within electronic medical records gives us access to real-time health information to include video conferencing capabilities embedded in electronic health records. Remote monitoring technology, Bluetooth, blood pressure cuffs, pulse oximetry, scales, etc., give us the ability to provide remote monitoring services into the home to be able to help with the management of chronic conditions. So let's talk a little bit about what's happening in Montana. And I want to put this in perspective of 3 buckets and a side note. And this is the way I think about telemedicine. Other people may think of it in a different way, but I think of it in 3 sections. I think of it in direct-to-consumer. I think of it in an ambulatory care perspective and acute care perspective. So what's happening in Montana from a direct-to-consumer perspective? We have multiple providers within our region that are providing direct-to-consumer care for basic primary care needs, cash and carry. I pay you $45, I have a sore throat, my kid has a earache in the middle of the night. I connect from my home through a laptop to a provider to do an evaluation on that patient. We also have employer-based direct-to-consumer technology and programs in which employers are purchasing that direct consumer product for their employees to give them an added benefit. So both of those applications are occurring in Montana. Ambulatory care, which probably has been the area where we've been grown the most in Montana and have been kind of in the forefront in Montana, really has to do with kind of that specialty care being provided out from another facility, from a facility to another facility. So things like oncology, cardiology, nephrology, ped specialty, it's that outpatient care that we're bringing in specialty services into a community that may not be available in that community. And also, we're beginning to see some primary care support in our communities. So, direct consumer, ambulatory care, can't forget mental health and addictions. We got to put that in there. Those are the things that kind of been our greatest growth and our biggest volume in Montana. Acute care is kind of a very interesting area when we talk about patients located in an emergency room, telestroke, tele-AD, telepsych, acute management of patients, telehospitalists, tele-ICU. All of these applications are occurring within Montana. The other thing that I want to talk about just for a minute, I think this, because I'm excited about this, I just returned from the Meta ECHO conference in Albuquerque. And I think ECHO is an amazing resource for this state and will continue to grow and be an opportunity for us to help providers provide care more successfully locally. And the ECHO model really is a didactic education with an expert panels connecting two people joining into ECHO that present cases to manage those patients real time. And I just think it's an exciting opportunity in the state of Montana. So let's talk about where we're providing this. Where are we providing telemedicine services? We're providing it in hospitals. We're providing it in critical access hospitals, ICUs, EDs, FQHCs, rural clinics, mental health centers, school-based clinics, nursing homes, and home. And I just learned about a jail program that has just started, jails and prisons, pre-release centers. It's amazing the variety of location. Now that's where the patients may be located, but the interesting thing is we have providers located in all these places as well. We have a psychiatrist that practices out of Bozeman that does all telepsychiatry from her home to a critical access hospital. So location and where these services can be provided happen all the time. So let's talk a little bit for a few minutes about who's providing these services. So Montana providers are providing services to Montana patients. Subspecialty providers from outside of the state of Montana to patients and providers are providing those services. We typically, in Montana, have had relationships with people like Seattle Children's, like University of Utah Salt Lake, like Denver Children's. And all of those facilities are providing telemedicine services to patients in Montana. The other piece, which is kind of, it's a new idea and concept, but the largest growing area of telemedicine today are service providers. And so what is a service provider? A service provider is a business that basically provides telemedicine services of some kind to a consumer. So for an example, some of the names you may hear, American Well, Doctors on Demand, Carina. Insight is a telepsychiatry company. It's a service provider that basically aggregates demand and sells that demand to whomever that needs that demand. So that service providers provide that service. And you can go out, to tell you the truth, pretty much today you can go out and buy those services anywhere. Sometimes they're a little expensive, but you can buy those services. So why is this exciting for me? I could say that if I could recruit 10 psychiatrists to my organization, I could keep those 10 psychiatrists busy doing telepsychiatry without a problem at all. I can't recruit 10 psychiatrists to my facility. We can't. No, we can't recruit them. But we have companies and good service providers that can aggregate demand and aggregate a resource together that will be able to provide those services to them. So why has this change occurred? And to tell you the truth, I'm excited about the change because it brings resources to Montana that we may not have been able to get in the past. So key factors in growth or change, I think absolutely cost-effective technology, video platform, Zoom, all of these technologies that are HIPAA compliant. We have payment models that are meeting the needs from both third party and of course a shift into a pay-for-performance model. We truthfully have greater acceptance from providers and patients alike. And that's exciting to see. We've got young physicians and other healthcare providers that are coming out of school that expect that they have this resource at their fingertips, which we find very exciting. And I think the other part is we have complex problems, and we need the ability to address those complex problems with creative solutions. And I think telehealth and telemedicine is important as we look at the challenges that healthcare face today. So telemedicine will always be about providing the best clinical experience possible for the patient and the provider. This takes attention to all clinical aspects. So having the right equipment for the type of encounter, whether it's an electronic stethoscope, a patient exam camera, you need to have trained clinical presenters if you need them. You need to make sure that the connection is secure and HIPAA compliant. That you need to ensure that appropriate clinical information is available at the time of the encounter, and distributing information back to the patient care team. I would say that our biggest challenge in telemedicine is not the technology, but it is the people and the ability to provide care in the right way. And I'm going to end up with a word of caution for everybody, is that just because we can do it doesn't mean we should. And there are some things that we probably should not do. Telemedicine's goal should always be to provide safe, effective, high-quality care and ensure that the continuum of care is maintained.
Good afternoon. As the slides are getting loaded up, I want to take you back to a time before my slides are represented here. Summer of 2014, only 3 years ago, but what a different world we had in terms of telemedicine regulation. I go back to that summer because I was asked to make a presentation on telemedicine in Montana and telemedicine regulation to a group of doctors from the Ukraine who had fairly limited English. And so imagine just trying to do the translation for some of the statutes and rules and technical language. Well, at that time, telemedicine in terms of regulation with the Board of Medical Examiners really involved doctors who were working out of state, mostly for large companies like VRAD, who were doing consulting work as pathologists or radiologists, and they were working with Montana hospitals, and they had what was called a telemedicine license. And it was a limited physician license. If you held a telemedicine license, you could never come into the state of Montana to practice. You had to be out of state. It cost less, but it required certain other things for licensure that an ordinary physician, if physicians are ever ordinary, never had to provide. You had to have proof of malpractice insurance. You had to have specialty certification, which a physician coming in for a physician license didn't have to have. So in 2013 and 2014, as the medical board was looking ahead to the 2015 legislature, one of the things that became clear is that the telemedicine license as a specific license type really didn't make a whole lot of sense anymore. And so the board went to the legislature and made some changes. So here's where we are at the moment. As a result of the 2015 legislature, I realize this is a lot of text, but I wanted to put it in context for you. The yellow is what's important. The definition of the practice of medicine was changed in 2015, and for the very first time, the word telemedicine occurs in it. This was done because the telemedicine license itself was removed from statute. Starting in July 1st of 2015, the Board of Medical Examiners stopped issuing telemedicine licenses. And anybody that had one was converted to a physician license during the course of that year, which actually expanded their scope of practice. One of the reasons for this in the minds of the medical board and with our supporters was medicine is medicine. Whether it's practiced over distance or whether it's practiced face-to-face in a doctor's office. And a physician really is a physician regardless of what the context is of the practice. So we have the definition of practice of medicine now includes electronic and technological means such as telemedicine. Here's another thing that happened. The definition of telemedicine was moved, it was copied from a statute on insurance coverage to the list of definitions for the medical board when it comes to physician regulation. Now, this was not something that the board actually had proposed be included in the law, but Legislative Services said if we're talking about telemedicine in statute for the medical board, we have to have a definition, and this is the one that existed. So you'll note that the term does not mean an audio-only telephone conversation, email, instant messaging, a fax transmission. It has to be more than that to be considered telemedicine. This is actually pretty consistent with what the Federation of State Medical Boards put out in 2013, 2014 in a policy there's a kind of guidelines, recommendations to states for how to regulate telemedicine, how to put some borders around it. Because the Federation and its committee, called the SMART Committee, one of whose members is Dr. Anna Earle, who's a medical board member now in Great Falls, used to be in Chester. That committee concluded that while you might have a very broad scope of practice for physicians in your state, telemedicine does require a little extra attention. And so it did propose that there be some specific regulations for telemedicine. So 2015, Senate Bill 77 goes through the legislature, passes very easily. We see the end of the telemedicine license. We also see the end of temporary licenses as a specific license type. We get a little more statutory language regarding medical residents, most of whom are in Billings, some in Missoula. And we get telemedicine incorporated into the state law. The board knew that once these changes went into effect, there would need to be some rulemaking, and that's where the Federation's telemedicine guidelines came in. And so there was a working group that was created, a couple of board members, Thelma was in it, a couple of physicians that she recommended, the Medical Association was a part of this, the Hospital Association, and it was really designed to give the board an advanced sense of what the landscape is and what the landscape might be when the law was changed. Assuming that Senate Bill 77 passed, what should the medical board be thinking about in rulemaking? Well, there were a number of things that were going on at that time, and among them, were these notions of the physician-patient relationship. And how should that be defined for telemedicine? Well, the interesting thing is Montana, we don't even define physician-patient relationship for an in-person doctor-patient relationship. There's nothing in statute, nothing in rules that defines that. So then we're faced with a question, well, do we have something special just for telemedicine, or do we need to do something for all physicians in all circumstances to define that relationship and to ensure that a bona fide physician-patient relationship exists? Big concept, treatment occurs where the patient is located. This is something that really first was articulated when the Interstate Medical Licensure Compact was adopted in Montana, because that's part of the statutory language of the compact, is that it's where the patient is that counts. If you could have a doctor at the Mayo Clinic in Minnesota and a patient in Montana, and if a complaint comes in against that doctor, we don't want to go chasing to Minnesota to try and get action. The complaint should be heard in Montana where the patient is. And then as I noticed, as I said before, medicine is medicine. There should be the same standard of care should be in place for telemedicine as for, I'll call it just in-person medicine. Now with all of these slides, you'll note I don't have the official rule language. I'm not going to do the strikeouts and the underlines. I think that would just be confusing. So these are concepts that the board has been working with now for a couple of years. And essentially they haven't changed a lot in a couple of years. These are still the concepts the board is working with. Now, how should a physician-patient relationship be established for purposes of telemedicine? Well, it could start with an in-person interview and exam where you do have a face-to-face, and then subsequent interactions are done through telehealth or over distance. It could be a consultation with another provider who already knows the patient. So Dr. A knows the patient, says, I'm going to have you work with Dr. B. He's away from here, but telemedicine can allow you to have an interaction with that person. Or it can be done with telemedicine technology itself, if there's a good reason why an in-person consultation is not necessary. Now, if a physician is going to use telemedicine, are there certain things that the physician should, shouldn't, shall, cannot? What's in the thou shalt and what's in the thou shalt not category? Well, the Federation's guidelines, which the board used as its initial template, if you will, says that patients got to know really who that doctor is, and the doctor has to know who that patient is to the greatest degree possible, so that we don't have people, in a fraudulent situation or seeking care fraudulently. That relationship has to be established. Medical history has to be obtained, because for standard of care purposes, we want to make sure the physician is thorough. And we also want to make sure that the records are maintained and that they are available to the patient or to other providers, just as with the typical doctor-patient relationship in an office. Delegation. This is a topic that actually has caused quite a bit of discussion in other states, because other states have placed rules about telemedicine in their body of rules. So if a physician wants to delegate to another provider, be it another physician or let's say a physician assistant in the office, well, you have to know that that other person is qualified, and it's got to be a licensee. Maybe that physician assistant or that other person already has a relationship with the patient. And you want to make sure that if it's somebody, if you're the primary doctor in this relationship and you're not going to be seeing that patient very often and you delegate to somebody else, you got to make sure that person actually has access. All right, the other thing that happened, well, the thing that already has happened because of the 2015 legislation eliminating the telemedicine license, is that the board already has removed any rule that was on the books regarding that license. It had very little to do with practice. It mostly had to do with how you apply, how your license is granted, how you go about renewing, things like that. All of those are gone, and now the only telemedicine rules that are left really deal with the definition and the practice of telemedicine. And that's what the board is still working on. Why is it still working on these rules? It's been 2.5 years since the legislature passed it. It's been more than 2 years since the law went into effect. Why do we still not have telemedicine rules? Few reasons. And some of them are external. We had the bill pass, but then as that bill was going through the legislature, the court system was still dealing with the North Carolina Dental Board case. And that was throwing a lot of uncertainty into any kind of regulation for any sort of license type. And early in 2015, we get the US Supreme Court decision on this, and I'm sure you're all familiar with it. We have become very familiar with the terms active supervision and market participant. And the bottom line is, and the cautionary tale for any sort of regulatory board from that case is, be careful when you are placing new regulations on any sort of licensee that you don't step over a line and end up having to take those back, or get yourself into a legal situation with the FTC and maybe get a very expensive regulatory case or a court case. So at the medical board, we were very cognizant, and when I say we, I'm talking not only myself, legal staff, the Department of Labor and Industries, top legal staff, as well as members of the board, very cognizant about tread carefully, because there are lots of people out there watching, and when a board is thought to overstep, they are ready to pounce. Here's another one, the Teledoc case in Texas. The Texas Medical Board put in telemedicine rules and were pretty much instantly taken to court by the Teledoc organization. And Teledoc has been fairly successful in this. And so that was another thing. Do we, as a regulatory entity, want to travel down a path where it might be shut off because of other activity in the courts? So those were two big factors that we had to consider moving forward with regulations. Then 2016 comes along, and we learn that there's going to be a bill in the 2017 legislature to actually place limits on telemedicine in statute, brought by the Montana Medical Association. Well, it got in the legislature. The medical board put all of its potential regulations on hold to see what was going to happen here, because statute always trumps rules, every time. So House Bill 389 went into the legislature. It got through the House just fine. There were no issues. The medical board stood up in support of it. Obviously, the Medical Association was in support of it. Quite a few other folks stood up in support. Two main opponents, 1-800-CONTACTS and Teledoc, who had attorneys there and lobbyists there. They spoke to the committee, and I'm guessing they did a lot of work in the halls. It got through the House. It went to the Senate. Same thing in the Senate hearings. Everything seemed, a lot of people speaking for it, these two organizations speaking against it. It gets to the Senate floor, and suddenly we're hearing senators on the floor say, we don't believe Montana has enough broadband capability for this to work. And so it died on the Senate floor and was never revived. So it fails to pass earlier this year. And so the board, thinking, all right, we pretty much have a better understanding now of North Carolina. We have a better understanding of Teledoc. We don't think we're going to do anything that's really going to put a damper on competition or get us into real trouble with the FTC. Let's think about these rules again. Well, the board has not yet officially put rules to a notice, what we call a notice of proposal, where they go out for public comment. But I'm certainly hopeful that at our November meeting, the November meeting of the board, that will happen. So we've got an additional wrinkle that is from the MMA, the Medical Association. They had it in the bill in 389 that put some definite limits on the prescription of controlled substances by physicians. That is not part of the existing proposed rule language that the medical board has, but the Medical Association really wants the board to adopt the language from the bill that would require that a controlled substance prescription happen because of an in-person encounter, that it requires that you cannot do it via Skype or some other thing. The Medical Association really wants it on the books somewhere so its physicians know if you're going to prescribe controlled substances, you have to start with an in-person visit. The board is also, frankly, waiting on language for some other rule changes before we put a notice of proposal out. The way we try to construct these is to get the most bang for the buck. If we're paying for the legal process of changing rules, we want to get everything in there we can. For instance, there was a bill out of the last session that allows physician assistants to delegate to medical assistants, unlicensed personnel. That's not in there now. It will start in October with the adoption of new statutes. And so the board is trying to come up with a way to amend its rules on medical assistance, not only to include PAs in there, but also to restructure the rule, because right now it's very long, very convoluted, kind of hard to understand. And there are some other things the board would like to get in there too. So we are trying to get as much language in that proposal as possible. Telemedicine will be, I assume, a part of it, but it won't be the whole thing. Let me talk now about the compact. The medical licensure compact is really not all about telemedicine, but it is seen as an assisting device for telemedicine. The purpose of the medical licensure compact is to allow doctors to get licenses in multiple states faster and easier, not cheaper. They still have to pay fees to the commission, they still have to pay fees to the state. It's not any kind of a national license or a one license gets you privileges everywhere. You still have to be licensed in every state you want to practice in. But the compact was really intended as a response to efforts in Congress to create national or federal licensure. And it was ultimately determined that the challenge was, how do you get physicians licensed in more than one state faster? The compact was chosen as the vehicle. It became a reality in Montana in 2015. The Compact Commission, which governs the implementation of the compact, first sat in October of 2015. And now I can report that as of really about a month ago, the compact is fully operational in Montana. And that means that we have licensed doctors from other states who have applied to the commission, been certified by their home states as qualifying, and have paid their fees, and their licenses have been issued here. I can also tell you that more recently, we have qualified doctors. We have issued the letter of qualification for Montana doctors to get licensed in other states through the compact. That was actually the bigger of the two challenges, because in 2016, the FBI said, we're not going to allow the Montana Medical Board to see the results of federal criminal background checks because your statute's not protective enough of that data. So we had to go back to the legislature in 2017, change the basic law on physician licensure to make sure that the board could require criminal background checks, both state and federal, and to ensure that that information could never be shared with another entity. So when we certify a doctor and issue a letter of qualification, we don't share if they had a criminal history. We don't share anything about that background check. It's either they qualify, they don't qualify. And so far, the doctors that have been reviewed have qualified for licensure elsewhere. So again, we are fully operational in Montana, and we have a new executive director for the first time for the compact, which is going to take some pressure off all of the different volunteers from the 22 states. Actually, not all 22 have commissioners named, but for all those states with commissioners that sit on the commission, everything that was built in the first 2 years was largely done on the volunteer efforts of folks like me and Dr. James Feist of Montana, who's on the commission, physicians, public members, and executives from all these other states. And now we have our first official staff person that will, I think, allow the compact to continue to grow and thrive. And I'm happy to answer questions about how the compact works. I didn't want to burden you with too much information today, so I'll just leave it for questions at the end. But thank you very much.
Well, I'd like to thank my two colleagues for speaking for a long period of time. Katie and I were joking earlier, like, okay, who's going to be the one that speaks the longest from a payer standpoint? I'm Justin Mergel with Pacific Source Health Plans. I'm out of Helena, Montana. We roughly have about 40,000 members in the state of Montana currently. One of the things we look at in terms of telemedicine is really taking a look at how can we bring more access, more types of providers to the state of Montana where they're lacking in rural areas. One of the things, just a little history, I spent 14 years on the behavioral health side in the children's behavioral health with Intermountain Children's Home as a chief operations officer. And one of the things we always had struggles with was finding psychiatrists. Not from a service delivery standpoint, but from a regulation standpoint of having a psychiatrist be your medical doctor over your behavioral health your behavioral health system. And prior to myself coming over to Pacific, is that me? Sorry. Was shade left? Is that turn like that? Okay. Which way? Just to speak a little bit on that, as I transitioned to Pacific Source, one of the things we took a look at is some of our behavioral health contracts. You always hear as you come to these conferences, I like to move when I talk. I'll stay standing facing this way. We came into some shortage in Montana and rural parts of the state, and one of the things we looked at some of our members was we have a couple telemedicine contracts on the behavioral health side for Pacific Source for some of our Montana members more in northeastern Montana. And the reason why I bring that up is how it works is very similar to a face-to-face doc or a face-to-face behavioral health person or whatever type of specialty or service delivery there is. They have to follow the same protocols as anybody else in the state of Montana. For us, from a payer standpoint, you have to go through our credentialing process. You have to be licensed in the state of Montana, and then you have to be a contracted provider to provide telemedicine. And so we are really supportive of this. It follows our fee schedule. We also negotiate those types of contracts, what the service delivery looks like. Our health services team's constantly looking into how can we even evolve it further. Is there other providers out there that we would like to contract in the state of Montana that provide telemedicine into our members in the state of Montana? From an employer standpoint, one of the things that we are looking at doing in 2018 for all of our members is bringing teledoc. Some of those visits would consist of, flu-like symptoms, ear infections, nose, that sort of thing that doesn't necessarily take a face-to-face provider visit and go to the office. Because one of the other things we look at from our members is, okay, how much disruption do we want to give our members? They got a child that's sick in the middle of the night. Are they able to have access 24/7 to a pediatrician? Can they go into a telemedicine doc, talk to the pediatrician about what's going on with their child, get a script for ear infection, flu, whatever it may be, and so that doesn't disrupt their life where they're trying to get into a doc, that other thing. The other thing too that's has not been talked about from our perspective that we're looking at is, does this drive down the cost of health care in terms of ER visits, urgent care visits, that sort of thing? And so that's one of the things that we're still looking at, and I think time will tell with telemedicine if it's able to give better access to our members, quicker access for certain things. I do want to make note, it's for certain things, it's not for everything. And will it drive down the total cost of health care from people feeling sick and immediately going into the emergency room? So just want to reiterate, as we have members in 2018 come on, they will have the access to some of those services through our website, through Teledoc. So I think you spoke of it earlier about employers starting to do this, and this is one of the things as a health insurance carrier we're looking at bringing on as well. But we definitely would like to enhance our telemedicine panel, so to speak, and really follow the contract guidelines and everything else with our physicians here in Montana.
Hi, I'm Katie with Montana Medicaid. I'm the hospital section supervisor. I work with Lee Rhodes and Dwayne Preschinger back there. They're both trying to hide, but I'm not going to let them. Today I'm just going to kind of summarize what everybody's talking about with telemedicine, how it works for Montana Medicaid, and kind of the vision that we have going forward. Our goals are very similar to kind of what Thelma had outlined. We really want to improve access to the care that our Montana Medicaid patients and members have. We understand that our population can be extremely rural, and even with that, they also have limited access for travel and other barriers that could impact the way that they can access health care. So these are just relatively the standard definitions that go along with Montana Medicaid. We have an originating provider and a distant site, and then the telecommunications. So I will go through these relatively fast. I put a lot on the slides, but most are just for reference later. Small, I have a tendency to do that. The biggest part of telemedicine is, for us, it's similar to what Ian said. Medicine is medicine. How it's provided isn't necessarily what we care about, as long as it's provided with a quality aspect that you would do if you saw a person in a face-to-face nature. Given that we don't have any rules presently in Montana Medicaid that regulate how it functions, we just have this standard, you should bill it appropriately with all the modifiers, place of service, etc. in order to get proper reimbursement. I did it, doesn't matter about my height. The big caveat for Montana Medicaid, and we run into this a lot, is as a distance and originating site, you cannot have the same tax ID. So you can't be using one of your affiliates that gets the same source to receive the reimbursement from Medicaid. And into that, they can't be within the same community. You can still bill one of those services, but you wouldn't be able to bill both. We allow a substantial amount for an originating site. We don't have any different enrollment process for telemedicine. If you're enrolled as a Montana Medicaid provider and you fall within that list, you will be able to provide telemedicine services to our Medicaid population. In the originating site, one thing that is a little different for us than in regards to Medicare is we do allow rural health centers and FQHCs to be an originating site. This provider is, you would bill with your Q code. The caveat I'm going to throw out here is all rates that you see for Montana Medicaid are present right now, subject to change in the near future. Sure, that's no surprise. And as the distance provider, it really would be as if you provided that service in an in-person visit. You would bill that claim with your appropriate code, you would signify it with the modifier for telemedicine with GT, and you would put your place of service as an O2. It just lets us know that that's how the service was provided, but when it comes to the reimbursement, it will be the standard Medicaid reimbursement. There is no differential for the distant site versus if you provided that service in person. So the big thing that we're looking into right now that I kind of wanted to touch base, it kind of went back to one of Thelma's first buckets that she kind of alluded to, is currently Montana Medicaid uses a nurse advice line for our members for potentially access to some medical advice, if you will, after hours. We're not overly thrilled with it. I'll just be quite frank with that. So what we're looking into is we understand that the market is changing. People are accessing healthcare substantially different. You're in an ever-changing environment. People want to be able to interface with a physician within their home or any other area. They kind of want it now. They don't want to maybe wait for a week to get in to ask a couple questions. So part of that is we recently, and I believe we got notice that the request for information is actually out on the street today. We are soliciting some information, if you will, from vendors and other sources to try to identify what's out there. One thing that we run into as Medicaid is since we're regulated by a lot, if you will, not everybody necessarily wants to engage with the governmental entities, but we were trying to understand what options there would be for the Montana Medicaid population to potentially bring what we were referring to as virtual medicine into the population. It's in its really infancy for us. The request for information is new for our division in a sense. We usually just skip straight to a proposal, but this one we're taking with a substantial amount of steps to make sure if we go that route that we can do it well. We know we'll need to interface with the physicians because we don't want to overstep where we want to go. We want to help understand how we can make it work for them and help make it work for our population. I believe that will close on October 9th. Hopefully we receive some pretty good responses from the vendors out there to help us get an idea of what will be available. And that's pretty much the end of mine. And if this presentation is available later, we did put the contacts of our various individuals within the Hospital and Physicians Bureau. I put Lee's name first. It's in order of how you would want to contact. He's always available. Oh, I could get that to you later if you would like.
And one for Ian. The regulations about providers delegating medical assistance. I'm not sure if I read I was looking at the current document, but it sounded like the way the rules are now that they can train them to do certain things. And what I'm wondering about is one of the things we're running into is the difference between, say, training a medical assistant to do something for the provider versus assisting them remotely as a telepresenter, whether they can be trained to basically set the patient up and do the presentation of the patient and kind of be the doctor's eyes, ears, hands, what have you, to assist them versus actually doing, say, an exam, say a neuro exam, for instance, if they're helping remotely. Can you speak to that at all as where the rules are, you think they're going and where they are?
The question is about medical assistants, which are unlicensed people who work in a physician's office. In fact, that's the only place they can work, is in the office of a physician or a podiatrist, because I know the podiatrists got themselves into the law when it was first passed in 2005. And can a medical assistant essentially do the kinds of things that they typically do in an office using telemedicine techniques? My answer is we haven't approached that yet. What the board and what I as a staff person for the board want to see occur is I want to take that medical assistant rule that was very difficult to craft in 2005, 2006 because of a lot of opposition from the nursing community. Take that rule apart and make it more understandable, for one, to really say, here's what a medical assistant can do, here's what they can do with direct supervision of a doc, here's what they can do with the doc, at least in the office, if not in the room, and here's what they can't do in any circumstance. And that's in the rule, but it's written in very convoluted language. There are exceptions and then exceptions to exceptions, very, very complicated. To date, the topic of medical assistants essentially being delegated telemedicine tasks has not emerged as a topic for that rule. In the delegation portion of what the board's considering for physicians in telemedicine, it only speaks to delegation to licensees. So delegation of telemedicine could only be done to another doctor or a nurse or a PA. I can certainly take your question back and chat about this with the board's counsel, whose task ultimately is to write a new medical assistant rule and suggest that, is that something that can be looked at. But for the moment, the short answer is it hasn't been considered, and I don't know exactly what that would look like, but that's an intriguing thought.
The key word would be telepresenting and how that might apply if that's different than actually treating them to do.
All right, you've used the term telepresenting. That would require a definition of what that is. If it's going to be in the rule, that better be defined very, very clearly. Right now, I mean, a medical assistant can do, patient prep, take vitals. I mean, they can do more than that, but I think that was a major function of medical assistants in the beginning, where physicians said, we need to have it in the law that we can tell them to do that, as well as deliver, an immunization or a shot or something. And could that be done remotely via, distant technology? It's a reasonable question. I don't have an answer for it yet, but thanks for bringing it up.
Yes.
I'm kind of curious about the status of various apps and that you can download, on your phone. I think that there's one that has like an EKG that you can how reliable are those systems and how do you regulate what is in an app?
Thelma, you want to take that?
All you, Thelma.
Well, a couple of things. There's a lot of discussion about apps and medical devices and FDA approval and how well they work. A lot of that depends on whether you're transmitting that from Ekalaka or whether you're transmitting that from Sydney or Glendive, and what telecommunications support you have and what the cell service has. So I don't think there's really any good answer. I can't give a specific answer. I would say, first and foremost, if you're looking at an app as a telemedicine app for a telemedicine application, you want to make sure it's FDA approved. That you're using a encrypted, secure method of communication between provider and patient or provider and provider. And that you test them out for ease of use. Now, we have a resource standing at the podium, the Telemedicine Technology Assistance Center that's based in Alaska, but Doris works for them, does a lot of work around telehealth technology and evaluation of technology. And I think you guys have done some work around apps.
We have, yeah. If you go on our website, telehealthtechnology.org, we've done some toolkits, not only on apps, but on the mobile health devices. When you were talking about, being able to take your EKGs using your cell phone, there's hundreds of applications like that. They have otoscopes, they have stethoscopes, they have exam cams, they've got all of that stuff that you're using from your mobile apps.
Good to know that it's FDA, that there's ones that are specifically FDA regulated.
Yes.
And just looking for that would give some peace of mind.
Let me speak to.
And I would say, I'll go back to that, just because you can, doesn't mean you should.
And since you mentioned regulation, an app that you can use to take your own heartbeat or measure something, measure a vital on yourself, that's not really diagnosis or treatment. That to me doesn't seem to fall within the definition of the practice of medicine. If it's the app that's actually assisting someone diagnose you, that's where I think regulation comes into play. And just in general, I'll say the challenge in regulating telemedicine at the state level is you have to craft something that's going to be applicable to the doctor at Billings Clinic who's treating someone in Ekalaka within the state. That also has to apply to somebody at the Mayo Clinic treating somebody in Montana. And it also has to apply to the teledocs and the kiosks at CVS with a doctor at the other end. How do you craft something that's going to apply to all of those with equity and fairness and public protection and the ability to go after somebody for a violation of standard of care or an unprofessional conduct? That's really the challenge, and that's why I think the medical board has tried to really focus on just the basic things that need to happen in a physician-patient relationship, and as that relationship starts and as it moves forward.
Any other, yes.
I had a question back related to the medical assistants, and the current law allows for medical assistants in doctor's offices only. So what about in our critical access hospitals where we had telemedicine for 25 years with...
Well, under the statute, this was about medical assistance in critical access hospitals. Under the statute, so even above the level of rulemaking, the statute says a medical assistant can only work in a physician or podiatrist's office. Now, there is, I guess the exception to that is, so, and they cannot work in a facility that is licensed by DPHHS, an inpatient facility. They can't work in a hospital. They can't work in a nursing home, but they can work in a doctor's office that's attached to a hospital. So they can't go on a ward, they can't go in the ER, but they could work in Dr. Smith's office that's like in the B wing down from the main hospital, but they've got to stay in that office. So does that help clarify?
So then in our critical access hospitals, we can telepresent.
I'm not aware of that, and I presume that's in a whole other body of regulations that have more to do with hospitals. But
There is no regulation, really. There really isn't. There really, at this point, is no regulation at all. The thing that we have always said is whomever's doing that, number one, needs to be trained. Number two, needs to practice if they are licensed. They can only practice within the scope of their license. So we would not ask LPN to do something that's outside of their scope of practice. We would not ask an RN to do something outside of their scope of practice. And we would not ask anybody that was trained to be a telepresenter to do anything that would put them at risk or the patient at risk. But there really, at this point, is really no regulations around telepresenters.
And I will say one more thing about medical assistants is that the ultimate responsibility for what a medical assistant does is on the doctor. The doctor has responsibility to assess the training and knowledge and skill level of that person. The doctor can't ask a medical assistant to do something the doctor himself can't do under scope of practice. It's all on that physician, and if there's ever a problem, it's the doctor that's going to come before the screening panel and have to answer for it. The medical assistant is not a licensed person, so that person's never going to appear before the board. It's all up to the doctor.
Wouldn't the facility still could be held liable if there's negligence or something, even if they are practicing under the umbrella of that provider?
Well, that'd be a DPHHS question if it's the facility. Because the medical board does not have any oversight of hospitals or medical facilities, only individual licenses. Did you have more? I want to make sure, did you have more that you wanted to address?
No, I think that's...
Okay, thank you.
So I have a question for our two payers. Yeah. So the question that I have is, I think one of the things that's occurring more often and a really emphasis is the management of chronic conditions, and that much of what potentially could be done to manage chronic conditions is done in the home. And so we know that Medicare site of service you can't even begin to talk about. But if today, if you as a payer, there is a service, there is a clinical service being provided to a patient that you reimburse for, can the home be a site of service?
For Medicaid, the originating site can be the member's home, but there is no reimbursement for the originating site then. You would only be able to get the distant site reimbursement.
Yeah, and on the commercial side, we have there's a little different leniency than on the government side. And like I said in my short presentation, was if it provides a quicker access in some of those needs for the member, and it's provided by a licensed individual, in some aspects, yeah, we would cover that depending on, it would have to be through the contract discussion. And there might already be it in the contract, so to speak. So we'd have to look at that from an access standpoint for our members. And that has come up multiple times over the last couple months, was some of the chronic patients waiting till the chronicness gets too deep and it's an ER visit, as opposed to, hey, I have this going on, and it turns into, you know, something bigger. So we do have some of those cases that are occurring in Montana. So yeah.
Is it limited then by the type of provider that's providing the care, like primary care versus cardiologist, or is it just if they are a licensed care provider?
Licensed care, and we really, one of the big things that we focus on is making sure that's linked back to the primary care physician, and so you have that coordinated care approach, more or less team-based approach. So if something's occurring with that type of member in this case, we definitely want it to be linked back. It could actually be a licensed social worker that's doing the telehealth, you know, with somebody that's dealing with chronic illness, that sort of thing. What's the symptoms? What's going on? Is it, you know, from a behavioral health standpoint, or is it a medical standpoint, or is it both and? What's the driver here? And can we actually provide telehealth that would support them staying in their home, as opposed to waiting till the symptoms get so severe they have to call 911 or go through the ER or urgent care?
And so will local providers have that opportunity with the third-party payers to be that telehealth person? Because if you contract with a group of providers in Texas to be your telehealth primary care physicians for that strep throat in the middle of the night, and it prevents clinic visits to our primary care clinics, what's going to happen to primary care? And how do you license that, and who gets paid, and how does all of that cycle through?
I'm glad you brought that question up, because prior on my drive down here this morning from Helena, one of the things I talked to our medical director about was that similar thing. Like, people are going to have the notion that we're just going outside of Montana, right? And people are just going to use the web or the phone call or an email, like, I got this going on, and get prescribed or whatever the treatment modality would be for that person. And that's not what we want. What we're looking at is quicker access for, like I said, the flus, the rashes, that sort of thing. However, we're also looking for providers in Montana that have that ability to, that are licensed, that can provide this telehealth. And that would be looking at doing it for our membership, or that would drive, we could drive membership that's in conjunction with they're already having a primary care doc. So.
Last Friday, the Texas Board of Medical Examiners released their rules. I just saw a news story on it this morning. We get these feeds from the American Telemedicine Association. And basically they don't, in there's no requirement for how that relationship is developed. They're staying away from defining what method should be used, not determining whether there's a phone or a video call or person to person. Just that there needs to be a relationship, and not saying how. Texas is a big state. I think there's 24 million lives involved in what will be covered by this. Will Montana take a huge cue from what goes on there? Especially, they've just been released. It's got to pass muster, not get sued by someone again. If it does all that, will that be some kind of a model for Montana?
Well, you know, you always, the question almost always comes up when you're exploring a new area of regulation. What are other states doing? And sometimes that's a bit of a crutch, because you're thinking, oh, we don't want to step into new territory. Let's see what's safe that other people have done. Or it can be a legitimate, hey, let's pattern on something that works. When Thelma was part of the first working group, the state that we looked to was Iowa, because that was one of the first states that actually put forth rules, and they were based almost word for word on the Federation of State Medical Boards guidelines. They just took the guideline language, turned it into rule language. Now, and this is Texas you're speaking of, right? In a way, I'm not surprised Texas has done that because I think that's a large part of what Teladoc was complaining about is we don't want to have to, our folks, we don't want to have that face-to-face requirement, and that's one of the things they were arguing in the legislature is you can't limit it in terms of how you establish a patient relationship if you take the telephone or electronic devices out of the, something that's less than a video link. They said we can't support, limiting that way. Will the medical board use Texas as an example? I can't tell you right now. I can probably tell you that the board's legal counsel is going to be aware of this and will be a factor in how the medical board continues to look at this topic for purposes of releasing it to the public for comment. But I'd say for right now, the medical board's comfortable that it has created enough options or enough variety in how a physician-patient relationship can be created that we're comfortable with it. But thanks for letting me know that Texas did that today. That's a new piece of information that might be helpful. Thanks.